to our weekly webinar. So glad you could join us today. This is the third installment of a series that we're doing on cardiac amyloidosis. So the first two have been really outstanding, and you're in for a real treat again today. So we just want to say thank you again to our sponsors, and then also remind you that you can place your comments or questions in the chat box up on the right of your screen. And there's also a tab that says viewers, where if you want to direct message one another during the presentation, you can do so. I want to begin by just introducing Dr. Keith Stockerell-Goldstein from Washington University in St. Louis. He'll begin our presentation today. So thank you, Keith.
All right, thank you very much for having me. Let's see if I can pick the right screen here. All right, well, thank you, Stephen. I'm Keith Stockerell-Goldstein. I'm a professor of medicine at Washington University School of Medicine in St. Louis, and I'm in the Division of Oncology in the BMT and Leukemia section. And my slides are not moving. Oh, there we go. Excuse me. Let's start with a pre-test polling question. Which of the following questions about the serum free light chain test is not true? A, the serum free light chain values can be abnormal in patients with renal insufficiency. B, the serum free light chain ratio can be abnormal in patients with renal insufficiency. C, the serum free light chain test only detects monoclonal light chains. D, serum free light chains can be normal in patients with untreated AL amyloidosis. And E, serum free light chains may be elevated in patients with autoimmune disease. And we're looking for the one that is not true. And a link should show up for you to vote. And I will begin. So what I'd like to do is really just go through the tests that we use in patients who have a suspected monoclonal gammopathy, and really focus this on patients who you may be working up for amyloidosis, where there's a suspicion for amyloidosis, and the question is, do they have AL, do they have TTR, or one of the others? And so I'm going to start in my favorite place, which is the bone marrow. And just a reminder of what that is in this case, the cells we're going to focus on are the normal plasma cells that in a normal bone marrow, we should see 1 to 5% plasma cells. And as you remember from immunology and medical school, plasma cells are the cells that are responsible for antibody production. And each plasma cell makes one specific antibody to some invader. And that's a normal situation. So when we look in the normal bone marrow, we should see a small percentage of plasma cells, and they should be a mixture of different types and not clonal. In the diseases that we're going to talk about that have monoclonal proteins, what we find is that there's a clone of plasma cells, so a single cell that's now making copies of itself, growing disorderly, and that can be for diseases like multiple myeloma, AL amyloidosis, as well as other things like monoclonal gammopathy with undetermined significance. And so all of these cells are making an identical protein, and the test I'm going to talk about will allow us to detect that. And just a reminder about monoclonal proteins that we're talking about here, the serum paraprotein is composed of either a partial or complete antibody. And again, just a reminder in this schematic that antibodies are devised of 2 heavy chains and 2 light chains that are identical. So the heavy chain is IgG type most commonly, but IgA less commonly, IgM, and then very, very rarely IgD or IgE in the abnormal setting. And then the light chain is either kappa or lambda. And so the tests we're going to talk about will help us detect those things. In the majority of patients with myeloma and MGUS, the patients have a heavy and a light chain, but there's a significant fraction of patients with light chain amyloidosis or light chain myeloma who only secrete clonal light chains. So the serum protein electrophoresis is the first test I want to discuss. This is a test where a sample of serum is placed on an agarose gel. There are some newer methods where this can be done in capillary tubes, but it's placed on an agarose gel and at the top of a well, and then electrical charge is placed over that. And over time, the proteins will separate on the gel based on their electrical charge and size, and will develop specific patterns, these 5 bumps in the electrophoresis. And so the first and largest, almost always, except in some situations we'll talk about, is albumin. So this is a measurement of the serum albumin. And then these peaks are labeled by their position and Greek letters, so alpha 1 and alpha 2 spikes, beta 1 and beta 2, which sometimes merge into one or have separation depending on the method that's used. and then this kind of broad spike at the end we call the gamma spike. And the majority of the immunoglobulins will show up in the gamma spike, but they can, especially IgA, show in the beta spike. In patients who have a very, very small amount of protein, we may not be able to see it. And in patients who have light chain disease like AL amyloid, sometimes those very, very small proteins migrate in other parts and are difficult to find here. The key thing here is that the serum protein electrophoresis tells us other bits of information besides monoclonal proteins. We can detect patients who have nephrotic syndrome, patients who have liver disease, and so on. And this on the right side is an example of what a gel would look like. So this is the top of the gel. A protein was placed across and then stained, and then a densitometric scan is done and leads to these peaks. So this very large one at the top is albumin, and then you can see the alpha 1, alpha 2, beta 1, beta 2, and gamma. And I'll show you some more examples of this as we go along. As I said, we can see different patterns. So the protein electrophoresis is ordered to look for clonal processes, but we can sometimes see other patterns. For example, in patients who have nephrotic syndrome, for any reason, you'll see a very low albumin and peaks that look different than this normal at the top. In patients who have a monoclonal gammopathy with a detectable peak, it will look like something like panel F here, where again, in this very end gamma, instead of having this very broad low band, you see this very high peak, where we would call an M spike. It's actually higher than albumin, so it tells you that it's very large. And over here on the left is an example of the gels themselves that I had mentioned. So the bottom is a normal gel, and you can see these bands on the top gel. This is a patient who has multiple myeloma, and you can see that there's this very large band here in this end region and the gamma region that is a monoclonal protein. The reports are sometimes hard to interpret, and it depends on the institution and who runs it, but this is just a breakdown of what we were showing on that tracing. So here is the amount of total protein in a patient's serum, and then each of these peaks, the albumin, the alphas, the gammas, and the alphas, betas, gamma. And you can see that in the gamma globulin fraction, so this fraction at the end, there is larger than normal, it's 2.1. And then very specifically what we're looking for, if the pathologist can detect a monoclonal spike, a peak somewhere hidden in there, they can then quantify it. So in this particular patient, they had a peak measuring 1.9 grams per deciliter. And again, in a normal situation, no monoclonal peak would be detectable. One of the things that I think is sometimes difficult to think about is that these terms alpha, beta, and gamma have nothing to do with the actual composition of the monoclonal protein. It's just the position it shows in the tracing. So if this is a restricted peak gamma, it doesn't tell us that it's an IgA or an IgG or an IgM. It doesn't tell us if it's a kappa or lambda. It just tells us there's a peak that's detectable and quantifies it. And sometimes the peaks are so low that we can't detect them, or there's a hint of a little bump in one of these, and it's so small that there's no quantification that can be given, or identifying that there's clearly something there. So the next test that we ordered besides the serum protein electrophoresis is the serum immunofixation electrophoresis, which is basically the same identical thing. This is an immunoelectrophoresis blot. And what you can see is there are basically 6 identical columns. The first one will be the standard serum protein electrophoresis, but what's done is a small sample of patient's serum is placed at the top of each column. The electrical charge is placed across this, and again, we see the proteins migrate down. What's different is this is that the columns labeled for the specific heavy chain IgG, IgA, IgM, and then kappa lambda have antisera to those specific proteins placed on it, and you get something that looks like this. So I'm going to start here and kind of walk through this. This first is basically the standard serum protein electrophoresis. So again, identical sample is placed on all of these, and you can see you're going to be experts now at reading SPEPs. Albumin is up here, and here is a peak probably in the gamma region that is much darker. And so as you walk across, it's very easy. You can see that at the same level as this peak, this monoclonal peak, you can see that IgG lights up and that kappa lights up, and we don't see lambda, IgM, or IgA at that position. So this would identify the protein as an IgG kappa. So again, the immunofixation gives us two bits of information. One is it is much more sensitive, so we can see smaller amounts of proteins that might be hidden in those peaks on the SPEP, as well as identifying the specific heavy chain and light chain protein as well. The sensitivity of the standard SPEP goes down to about 0.1 grams per deciliter. Roughly, again, it depends on the lab and the method that's being done, whereas the immunofixation can get into the range of 12 to 30 milligrams per deciliter, so about almost 1 log improvement. So we often find in patients who have very low secretion of proteins, and this is actually fairly common in patients with amyloidosis, with light chain amyloid, that the SPEP may look normal, or at least show a peak that's unquantifiable, but then when we do the immunofixation, we can detect these very small amounts of protein. There are a number of disorders associated with monoclonal proteins besides AL amyloid, multiple myeloma, and AL, the most ones we talk about the most, but monoclonal gammopathy of undetermined significance is a disease or disorder which we see in increasing amounts in the population. It generally does not turn into a malignancy or AL, but it's important to recognize that if we look at patients over the age of 70, 5.3% of the population has a monoclonal protein that's detectable. And I think this is important when you hear from Dr. Zor about the fact that just finding a paraprotein doesn't necessarily mean a patient has AL. And in the age group that often gets TTR amyloid, we know that they just statistically a few percent of those patients will have a detectable protein. The serum free light chain test is the other test that we use. It's a newer test. What it does is look for a hidden epitope on the light chain. So again, here's the heavy chain and the light chain, and there's an epitope that's hidden when the light chains are attached that is detected by the serum free light chain test. Very important, you can order a test that's called light chain test, but you want the serum free light chain test. And these small proteins are detectable. We all have a small amount. It detects both clonal and non-clonal. So a normal patient, or me, if I consider a normal patient, does have low levels of light chain. But this test is able to give us, again, very small amounts of free light chain. This is an example of a test in a patient with light chain lambda amyloid. As you can see, their lambda light chain normal is up to 2.6. Theirs is 13.2. Their kappa is normal, and they have an abnormal ratio. And the free light chain test, again, is not specific for light chain amyloid or even monoclonal gammopathies. It can be elevated in patients who have renal dysfunction, since the free light chains are cleared by the kidneys. And it can also be elevated in situations of infection or inflammation, so autoimmune disorders, acute and chronic infections. So going through those tests very quickly, one of the things I haven't mentioned is we can do the same thing to urine that we do to serum. And so the other test that we order on these patients is a 24-hour urine collection where the urine proteins are concentrated, and we do the same type of testing that I mentioned. So just to close, and I have about a minute, this is a study that looked at 110 patients who had untreated AL amyloid, trying to see if you ran these different tests, what percentage of patients had an abnormal test. And so the serum immunofixation was only able to detect 69% of these 110 patients had an abnormality in their immunofixation of the serum. The urine was a little more sensitive. It was able to pick up 83%, and that is because the free light chains do show up in the urine in the normal situation. Looking into the serum free light chain ratio, that new test that I mentioned was able to detect 91%. Adding the serum and urine immunofixation increased the percentage of patients identified up to 95%. And the key thing is the bottom two lines here. The abnormal kappa light chain ratio on serum immunofixation alone, or with the addition of urine immunofixation, was able to detect an abnormality in 99% of patients. So in terms of looking at a patient who you suspect has amyloid of some type, these are the tests that we recommend doing: the SPEP, the immunofixation, the serum-free light chains, and then a 24-hour urine collection for protein protein electrophoresis and immunofixation. And we can talk more about the intricacies of urine collection at the end if there are more questions. Thank you. And I'd like to turn the presentation over.
Sorry, Keith, not trying to break up your flow there, but there was a question that I thought, since we're doing okay on time, that Dr. Stephanie Feldman put in, and she asked, and you kind of answered it on your last slide or two, but maybe you could re-answer it. That,
sure.
Do you recommend everyone have immunofixation or SPEP with reflex to IFE? Is that an acceptable process?
Actually, in the patients you suspect amyloid, if you're doing that workup and you're considering amyloid, the recommendation for me would be to do the protein electrophoresis as well as specifically ask for the serum immunofixation. Because what we find in some patients and much more commonly in the AL patients, they have such a small amount of protein. So the way the reflex would work is if the pathologist sees a tracing of the electrophoresis, like I showed you, and they don't see any abnormalities, any blips that suggest there's an abnormal protein, then the reflex will not happen. The only time the reflex immunofixation will happen is if the pathologist sees a peak, either clearly quantifiable or a hint of a peak. And so we have many patients, and again, these are much more common in the AL patients than the myeloma and MGUS, where if you do the immunofixation that wasn't reflex, that you'll pick up a percentage of people that do have a paraprotein.
Fantastic. Yeah, and I think that, obviously Keith knows all about these details, but as a practitioner who orders these tests and you ultimately get some result back, the only time that I feel good about it, I suppose, is when all the tests are completely normal. The other option is if it's like so unbelievably abnormal that no one could ignore it, then that's the other situation, because then I know I'm just going to call you. But the real issue is what you're talking about right now, which is many things are sort of in between. They're not really totally normal, and they're not really super abnormal. They're sort of somewhere mixed in. So, I mean, how do you sort of sort through that? Because I mean, I've asked you questions before where I had an older guy and he had a mildly elevated protein, and you said, "Oh, that one's not significant," but I couldn't really tell the difference.
Yeah, I think it's difficult, and it requires experience and knowing also a bit about the patient. I think to just throw another intricacy into it, if we think about a patient who might have an AA amyloid, which I know we're not talking about here in general, but the AA amyloids are associated with infection and inflammation. So a patient who has AA amyloid that's being driven by their rheumatoid arthritis, for example, and let's say has normal kidneys, their free light chains may be elevated because of their autoimmune disease. So it really takes knowing the results of the tests as well as the patient situation to really get a handle on this. And Dan and I, we have emails going back and forth all the time with, how do you make sense of these things? I think the key thing which comes up in all of these webinars is if we can't make sense of exactly what the protein means and there's a concern that there's amyloid, then we're going to go after tissue.
Super. All right, I'll let you proceed on then with our next speaker.
Yeah, so I'll quickly introduce Dr. Zor from the University of Sao Paulo, who's going to discuss confirmatory methods for pathologic testing.
Sorry, so hello everyone. It's a pleasure to be here with you today in this webinar. Thank you, Eidos, for inviting me. And we know that systemic amyloidosis is a protein misfolding disorder where insoluble fibrils are produced and deposited in extracellular space of different tissues and organs, leading to organ dysfunction. And at least 14 proteins are related to systemic amyloidosis. But when we talk about cardiac amyloidosis, we're talking mainly about two subtypes: light chain amyloidosis, named AL amyloidosis, or transthyretin amyloidosis, named ATTR. And we know that these two subtypes of the disease are totally different in its way of causing damage to the organ, and also in its form of treatment. We know that AL amyloidosis is a more rapid disease with more rapid progression, and because of the main toxicity, direct toxicity actually, of the light chains into the cardiomyocytes. So this is a real emergent situation, and we need to really make the correct diagnosis for plan the correct treatment for our patients. And the clinical manifestations do not help us in this way, because we frequently have a clinical overlap between different subtypes with the same clinical manifestations seen in these two subtypes. But when we face a patient with these two abnormalities, named the macroglossia and the periorbital purpura, we are in front of a patient with AL subtype. These two manifestations are specific for this subtype, but they are not frequent. Only about 15% of patients will present them. So we have question number 2. And what is the gold standard method to confirm the amyloid subtype in a tissue specimen? Immunohistochemistry, immunofluorescence, immunoelectron microscopy, laser microdissection followed by mass spectrometry, or all of the above. I'll give the audience some seconds to make the correct answer. So, to establish the diagnosis of AL amyloidosis, we need an histological evidence of amyloid deposition, and this is made by the Congo red staining that shows us a typical apple green birefringence under polarized light microscopy. And the diagnosis depends on the experience and the skills of the pathologist, and it's not infrequent that we face patients with a negative exam, and when a pathologist with more expertise looks at this specimen, he or she finds the amyloid material. And which is the best site for to perform a biopsy? We know that in AL amyloidosis, when we combine the fat pad and the bone marrow biopsies, we had a yield of about 85% in finding the amyloid material. But when we do not find the amyloid material with these two, in these two sites, we can go to a more invasive biopsy, biopsying the affected organ, such as the nerve, the kidney, or an endomyocardial biopsy. And it's important to point that the amyloid type and the burden of the disease influence in this positivity. So in AL amyloidosis, we know that the sensitivity of fat pad aspirate or biopsy is much higher than in TTR amyloidosis, and it falls to about 15% in ATTR wild type versus 30% in variant forms and 90% in AL amyloidosis. So to type our amyloid, it is important to type the amyloid for characterize correctly the precursor protein, because we need to plan the correct treatment. So we have immune-mediated methods such as immunohistochemistry, immunofluorescence, especially in kidney specimens, and the immunoelectron microscopy. We know that in experienced laboratories with many expertise and trained staff, we can reach over 90% of positivity with these immune-mediated methods. But we have some pitfalls in doing these immune-mediated methods, such as false positive and false negative. Just to exemplify, the false positive may be due to a non-specific background staining of other proteins, and the false negative may be due to a weak staining when we use especially commercial antibodies, and then they need, in some situations, to be combined with some other commercial antibodies or even in-house made antibodies. And the role of the experienced laboratory is another issue that is really important in making the correct diagnosis. We know that the gold standard method is the laser microdissection followed by mass spectrometry analysis. And here we exemplify in this video, we can select the deposit material area, and the laser cuts these parts of the material. And this goes under a process of digestion of the proteins present in that deposit material, amyloid material. It passes through a separation process in liquid chromatography and then go to the mass spectrometry analysis. And combined with this bioinformatics, we obtain the final list of the main proteins that compose that amyloid material. And with this way, we can correct and identify the precursor protein, and thus mass spectrometry is the most reliable method in making the specific diagnosis, the etiologic diagnosis of amyloidosis. It directly identifies the precursor protein in the amyloid material. It allows the identification of new types of proteins. Its sensitivity and specificity is close to 100%, but it is an expensive method, requires specialized laboratory equipment and a trained staff. It's important to point that one situation, we have a specific scenario where we can not perform a biopsy. So when we face a patient with clinical signs, symptoms, and imaging exams, leading us to think about the hypothesis of cardiac amyloidosis, and we perform all the screening methods for a monoclonal protein, a monoclonal gammopathy that we've just seen in the other presentation, and we combine these with a bone scintigraphy with DPD or PYP, and we will obtain a normal screening for monoclonal protein. So no monoclonal protein results, and a grade 2 or 3 uptake in the cardiac area in bone scintigraphy with DPD or PYP. So we are in front of a patient that mainly has TTR subtype. And in this specific case, we do not need to perform a biopsy, and we go through the TTR genotyping. It's important to point that in this study that concluded this non-invasive algorithm, 19% of ATTR patients did have a monoclonal protein found, and 10% of AL patients had grade 2 or 3 uptake in cardiac area in the bone scintigraphy. So it's really a challenge to make the correct diagnosis in some situations, and the cardiologists and the hematologists, they need to work together in defining and concluding these difficult cases. And with that, we go to our third question. Regarding the etiological diagnosis of cardiac amyloidosis, choose the correct answer. When a monoclonal protein is identified by serum and or urine immunofixation or free light chain assays, it confirms the light chain AL subtype. B, in the absence of a monoclonal protein after performing all the screening methods, and a grade 3 myocardial uptake on technetium pyrophosphate bone scintigraphy, there is no need for a biopsy, and the next step is TTR genetic testing. C. When an elder male patient has carpal tunnel syndrome and cardiomyopathy with grade 3 uptake on bone scintigraphy with PYP, the diagnosis is TTR cardiac amyloidosis and no further investigation is required. D. A biopsy is mandatory in all cases to confirm the amyloid subtype. E. All of the above are correct. So I'll give you some more seconds to find the best answer. And just to finish, I will present a real-life clinical case, a short one, just to exemplify the importance of the diagnostic process. With a previously healthy 67-year-old Caucasian male who was admitted on the internal medicine division in April 2015. He had dyspnea on exertion that had started 6 months earlier, a numbness of hands and feet, which had started 2 years before and were progressively worsening. And he had also a weight loss of 14 kilograms. His cardiac assessments with echocardiogram and cardiac MRI showed a moderate left ventricle hypertrophy with a septal thickness, a subendocardial gadolinium-laden enhancement, and a preserved left ventricle ejection fraction. PYP bone scintigraphy was performed and showed a grade 3 cardiac uptake. Electroneuromyography revealed a polyneuropathy with an axonal pattern, and an IgA monoclonal component was found in serum immunofixation. Fat pad biopsy was performed with which was negative for amyloid deposit, and bone marrow analysis showed 2% of clonal plasma cells, and the Congo red was negative, showing no amyloid in the bone marrow. So a nerve biopsy was performed showing the amyloid deposit. Immunohistochemistry showed both positivity of IgA and TTR, and mass spectrometry finally showed us an ATTR type deposition, and the TTR sequence for the TTR mutations showed a V30M, Val30MET mutation, leading us to the conclusion of a late onset V30M ATTR variant, ATTR hereditary. And here are pictures of the amyloid deposit in the nerve, and here the mass spec results. So with that, I finish. Thank you, everyone. And so we can go to the next presentation.
Yeah, so Dr. Soar, there is a, actually I put in a question just so that everybody could see it, but I would say not infrequently. So occasionally we will have this situation where we do some biopsy, whether it's a fat pad or even a bone marrow or even the kidney, and we see some evidence of amyloid deposition. So the Congo red is positive. And then we send it for mass spectrometry. And when they start to do the laser micro dissection, they say that they don't find enough or they don't find any amyloid, so that they can't type it. And so what have you ever encountered that type of situation where you have, from some biopsy, you have evidence of amyloid, but you're not quite sure what it is, and you do the definitive test and they don't see enough to define the fibril? So have you encountered that?
Yes, I did, but not that frequently. Maybe the material, the first material you obtain was more rich in the deposit, and I don't know if with the time it may be it may have the material became more scarce because of the quality of the specimen. I don't know if the transport and all of the process, but I did not see that with that frequency. What I see is when you do perform the biopsy in patients with more advanced stage, that's how patients come to me here in really advanced stage. So we have lots of deposited material, so we don't see that with that frequency.
Yeah, I suppose part of it may be, potentially a sampling error. So, you biopsy an affected organ, or say you got the sample from a carpal tunnel and the biopsy was just not very big, and the part that has amyloid in it may just be really tiny. And so then I think you just have, that's just the limitation of the laser microdissection. So that's certainly possible. And then we had a relatively small publication, but it's hard to get a huge number of patients that have biopsies. And in this case, we were looking at kidneys, and we were trying to define, whether the Congo red positivity was in the actual tissue or the connective tissue, or whether it was in the glomeruli, or whether it was in the blood vessels. And we created some sort of scale where if it was in the connective tissue and the glomeruli and the blood vessels, then that would be a higher burden of amyloidosis. And that's what you were kind of talking about. So I think that I do feel that the pathology expertise needs to continue to improve, because this is how we make the diagnosis in many instances. So just doing sort of a traditional Congo red stain with the technology from 1980 is probably not good enough in this day and age. So, I don't know what you think about that.
I think that the Congo red staining is sufficient when we have this amount of specimen. Like the kidney biopsy, frequently we see huge amount of deposit material. So the Congo red staining is sufficient in these cases. But maybe when you're talking about this carpal tunnel material or a fat pad in a TTR wild type that we know the positivity is lower, maybe we need some extra method. I don't know. And the mass spec can identify the Congo red. I don't know if maybe adding to the Congo red in the finding of the amyloid material, and before making the correct subtype also.
Great. So thank you so much for your presentation. That's really wonderful. So do you guys see my screen now? Is my screen up? Yep. Okay. Great. So let me close out this didactic part of this presentation, and I'm really going to talk about I'm going to talk about the genetic screening for familial mutations. So this is a huge piece of this puzzle. And, I think that we need to continue to think about how we can do a better job of screening. And, I do want to point out in the course of my lecture, the things that are available and really should be available anywhere in the world. My experience obviously is that it's available in the US, but I have had multiple interactions with people from other countries who are able to access these same opportunities. So to screen is. So as we were, and actually Dr. Zor had this in her slides, so I don't need to cover it much, but when we think about amyloidosis, there's really a very long list. And for the purposes of this webinar and also these lectures, pretty much we're talking about AL or ATTR, and that makes up 95% or more of all of the causes for amyloidosis. So then the one other that was mentioned by Dr. Stockrell-Goldstein was AA amyloidosis, or secondary, and that is felt to be related to some sort of inflammatory condition. These are the top three by far, and the top two really make up a substantial percentage, and AA is probably the next most common beyond those two. But what's listed here is a whole list of genetic mutations that may be related to amyloidosis, and they have a very unique presentation and they have a very unique outcome. So each one has its own sort of picture. And I think that it's not that you need to know about each one of these, but you have to keep them in mind when you say you find evidence of amyloidosis somewhere and your tests do not lead to AL or ATTR, then you need to start thinking about these other ones. So the key for screening for cardiac amyloid is really to understand the types. And, we've talked about this pretty much at each one of our webinars in this series. But again, bottom line is you need to know about AL and you need to know about ATTR. When we think about ATTR, there are two subtypes. One is familial, and it's estimated that this makes up about maybe 15 to 20% of the total number of patients with ATTR. And then the rest are in a category called wild type, which was formerly referred to as senile. And, we don't fully know what the cause of that is, but it is felt to be perhaps early aging process, although the mechanisms are still really unknown. And then the bottom line is that in regards to amyloidosis, the only way that you're going to diagnose it is if you think about it and whether or not it may be present, because it's until it's really end stage disease, it's not going to come out and hit you over the head. So you really have to put it in the diagnosis or the diagnostic pathway when you have patients that present with certain constellation of symptoms. The purpose of my talk is to not go over all of these things, but in the past two webinars and including in this webinar, we have talked about a number of different tests. And these tests are always helpful, or usually helpful. And it's pretty common, actually, at least in my experience, that, we need to get a lot of tests to really fully define what the cause of amyloidosis is. So all of these tests may not be done in one individual patient, but certainly all of these tests will be done in a complete evaluation of a patient with amyloidosis. So, you may do one or the other, and if you get a clearly abnormal result, you may not need to do every single test. But frequently, patients get multiple tests. So what about genetic testing? I would emphasize that this is absolutely critical. And it's so critical when the bottom line is that anybody that you're suspicious of ATTR amyloidosis, it's absolutely necessary to do genetic testing somewhere along the pathway. So This is our first question, and it's US specific. And Dr. Zor in Brazil would have a different answer to this question. But so this is for the United States. What is likely the most common familial mutation associated with ATTR amyloidosis? So A is T80A, B is V122I, C is V30M, D is I68L, E is G47A. So let's dig into this process a little better. When we think about the characteristics of ATTR cardiomyopathy, as was mentioned before, the most common version is wild type, meaning we don't have identified mutation. And, it seems as though that this occurs probably in the range of 80% of the time for ATTR. There may be, depends on your location, whether that's a true statement or not, but overall, over the whole world, the estimate is somewhere in the range of 80% are wild type. And usually this is seen more commonly in men that are older, so greater than age 65. It's pretty uncommon in females, but it is not completely unheard of. And typically, at least as how we've identified it so far, is typically occurs in Caucasians. In terms of familial or variant or hereditary TTR, it's all called different things, but most people at this point in time are referring to it as hereditary TTR. And it's seen in both men and women, usually greater than age 65, but it depends on the variant. Some have early onset disease. The most frequent one in the US is V122I, and it was observed in the Southern Community cohort that 3 to 4% of African Americans were carriers. They didn't establish whether or not they had disease, so we don't know the concept of penetrance in at least with this mutation. And if you look at each individual mutation, they have different degrees of penetrance. So penetrance, as you all are probably aware, it just means you have the gene and it causes disease. So it penetrated to the patient. If you have a low penetrance, that means you have the mutation, but it hasn't caused the disease. And in terms of one thing we know for sure is that if you have a gene mutation for the TTR gene, that heart failure is much more common in that population. And then this part, the right side of the slide, just highlights, how the different genes may manifest. So V30M, which is a higher prevalence in Portugal and Brazil, and is similar to the case that Dr. Zor presented, is presents predominantly as a neurologic problem, whereas V122I presents predominantly as a cardiac problem. And then you can see the different variations of genes, mutations, and whether they have more of a neurologic or a cardiac type of phenotype. So the bottom line is you can really categorize patients with ATTR in two predominant organ systems, so cardiovascular and neurologic. And then the most common signs and symptoms are related to, on the cardiac side, are related to heart failure, and then of course atrial fibrillation. From a neurologic point of view, the most common signs are peripheral neuropathy and autonomic dysfunction. So you see the symptoms that are associated with those various conditions. So, how prevalent is ATTR cardiomyopathy. This is a moving target. So this slide was really from a couple of years ago. You could update it and change the numbers a bit, but I think as we get better at making a diagnosis and making it early, then I suspect these things are going to change. But first off, we've already talked about different things in regards to how common it is. But in African Americans, it may affect 3 to 4% of African Americans in terms of having a mutation, but whether or not they develop disease is still a question. And then in Americans of European descent, it looks as though amyloidosis may occur in 1 in every 100,000 people. But then, when you look at some recent studies, you see this was a paper recently published about patients who were undergoing bilateral carpal tunnel surgery, and they actually biopsied the tissue, and it was greater than 10% of the patients who had bilateral carpal tunnel ended up with a positive amyloid biopsy. And you say, well, okay, this is all wild type. But that's not true. If you look at even just these 10 patients, you see 2 of them had hereditary TTR, and then there were a couple that had AL. So, you may have a symptom complex that points you towards ATTR, but it really matters in terms of making a biopsy and a specific diagnosis that you may be making the wrong diagnosis if you don't go through a disciplined process. And then one other detail that I think is certainly interesting is that this was a paper a couple of years ago where it was patients that were referred to a hypertrophic cardiomyopathy center, and they looked at the cause of hypertrophic cardiomyopathy in those patients. And what they ended up finding is that over 9% overall had evidence of cardiac amyloidosis. And actually some of them had, mutational related cardiac amyloidosis. So, the phenotype in this case was hypertrophic cardiomyopathy. And, you might say, well, we need to do genetic testing for hypertrophic cardiomyopathy. That's true. But I would say, first and foremost, you need to exclude amyloidosis. So I think that whenever you have a phenotype of hypertrophic cardiomyopathy, amyloidosis has to be on the differential. So this is one algorithm that's proposed. And this is from several years ago, but I actually like it in general. However, the only thing I would say is genetic testing needs to be done sooner. If you look at this algorithm, the patient is pretty far along the path in terms of potential diagnosis of amyloidosis when they finally do genetic testing here in the bottom right of the slide. And honestly, I would say if you've excluded AL by the serum protein testing that Dr. Starkle-Goldstein presented, and you're pretty convinced or very suspicious or definitely sure that they have some form of amyloidosis, at that point, you really should do genetic testing 100% of the time. And, bottom line is that there's a number of patients out there that may have a genetic mutation, but if it's never measured or if it's never tested, there's no way you're going to know it. So how do you actually do genetic testing? I think that there are a number of internationally available resources. These are the ones that are available certainly in the US, but I know that several of these are available in Brazil and Europe as well. So I don't think that there's going to be any country limitation in terms of accessing these resources. So first off is Invitae. You can sign up as an individual physician for a free screening service in your practice area. And this is a critically important option, and most people don't really know about it. There's also the Alnylam ACT program was created to provide access for not only testing, but also counseling. And the website is listed there. And then Ambry Genetics also has a program, and it's listed there, www.ambrygen.com. And then lastly, if you go back to the first slide that I showed you, you know, most of the time we got to consider AL or ATTR, but when there's the possibility that all the other very rare mutations are present, you're probably going to have to do whole genome sequencing to really do those, to really accurately test for a genetic mutation. The reason is that the screening programs are focused mostly on TTR, and for these true non-TTR variants, they may not show up in the screening process. So this is not a common event, but it is something to keep in mind. And then why is it so important? Because therapies are, at least in the United States, the determination of what therapies are possible right now are determined by whether or not there's a hereditary TTR. So the next couple of publications I'm going to show are drugs that are indicated for hereditary polyneuropathy only. So these are not, at least in the United States, not indicated for cardiac amyloidosis as of yet. Both of these drugs are being investigated in that population, but they're not currently approved. So it's absolutely critical that you do genetic testing so that you could possibly treat a patient with one of these two therapies. So the first one I'm showing you here is Patisseran. And the most important finding from Patisseran, besides the fact that it suppressed TTR levels and it improved overall outcomes in this population. If you just look at the blue arrow on the slide, it shows that nerve function actually improved with Patisseran. So I think that is a key piece to show to have a medication that actually improves nerve function is critical. When we look at inotersen, this was a similar drug, similar process. It showed an improvement compared to placebo, but it didn't actually improve nerve function, but it lessened the progression. So last question, what best describes a major reason that genetic testing should be done in all patients who have suspected ATTR? So I won't read all of those, and I would encourage you to take the survey in the chat box. And to just summarize, no specific genetic testing is required for AL. I didn't talk about that at all because it's not needed. But any patient with suspected ATTR should get genetic testing. Highly effective treatments are available if you have hereditary ATTR. Most TTR mutations are considered autosomal dominant and have highly variable penetrance. This is an important concept. And then family members should be screened, if appropriate, in any patient. And then other very rare mutations that are non-TTR related would require whole gene sequencing. So this is the overall summary slide, which really just kind of covers each of the presentations. So I would welcome back our other speakers to answer any questions that may be there. Okay, so I haven't been able to see the chat room while I was giving my presentation. Anything going on there? Let's see. So Keith, since it's not so critical to do genetic testing in people with AL, where in the process do you sort of take a step back and say, okay, we got to do genetic testing now?
Yeah, I think it partly depends because our clinics are so closely related in position. It's been easy for us to get the genetic testing kits. We don't carry them in our clinics, but cardiology has them. So we've been trying to get them in patients, especially those who come in who say they have a not a known family history of a hereditary disease, but patients who come in with family members who have had heart failure or anything or familial neuropathy. So we generally do that. A lot of times, the first time I get a hint of a hereditary, because I have patients with a negative history and they have clonal gammopathy of some sort, is when we get the mass spec back, which reports this patient the amyloid we've detected as a hereditary mutated amyloid.
Yeah, so we've gotten some real surprises when we do the mass spec. We had a patient in common where he had myeloma and had evidence of amyloid on his cardiac imaging, and it was kind of getting worse. We did a biopsy, and the results came back about 4 weeks later, and I was sort of assuming that it was AL because he had myeloma and was being treated for it. And as it turned out, he ended up with wild type TTR, and so that opened up a whole new problem. And but I do think that in that case, I had to do genetic testing after the fact, because I wasn't really because I thought that he had AL, that had to make sure that he didn't have a genetic mutation that was causing progression of his amyloidosis. So it can get pretty confusing there. So Roberta, can you comment at all in terms of whether genetic testing is available in Brazil?
Yes, we have many laboratories that perform the genetic analysis, but patients in the public setting has limited access, and we have mainly the opportunity to make the genetic testing through the support of some pharma industries like Pfizer, and that's the way we get it.
Yeah, and I would add that I'm pretty sure, although I'm not going to speak for these other companies, but those websites that I had in the slide, I don't think they limit their support to only a certain area. I think those are options really in any country as far as I know. So, but I would certainly ask them that, and if there's if some practice or physician group is having trouble getting access to genetic testing in some part of the world, we want to know about it, and maybe we can help facilitate that. But so anyway, thank you all so much. Time flies when you're having fun, right? So you're officially off the hook now. We really appreciate. I guess the last thing is can you show the results of the questions, the answers anyway? I don't know if we have those available or not.
Dr. Lenihan, we will be dropping the question for the post-test MCQs, and then we'll be showing the results. Thank you very much.
Okay. All right. Well, thank you all so much. Really appreciate all of what you've done. These presentations were stellar, and we really appreciate all of the effort you put into having these. So thank you again, and look forward to future educational events that we can identify and try to help move the field forward. So Thanks, Keith and Roberta, and have a good day. And we'll send you the results of all the questions.
Thank you very much, Dan.
Thank you all, guys.